Okay, hello everybody, and a big October welcome to this session, which will be looking at what we mean by quality sanitation in both urban and rural contexts. My name's Guy Norman. Until very recently, I was WSUP's Director of Research. Now I'm working part-time with WSUP, the rest of my time with my own consultancy company, Urban Research. I'm going to be moderating this session, but I'm going to keep that pretty light touch because we've got a lot of really fascinating stuff to get to. Sanitation quality, do we really understand that? I'm going to be a little bit controversial, and I'm going to say, obviously not. We don't understand sanitation quality. Many or most of us will know about the findings of the recent big sanitation health impact trials. And although the findings of these trials were in many senses positive and encouraging, in general, we're seeing that sanitation interventions as currently delivered are not achieving the health impacts that we would like to see. Now, there are many possible explanations for this and multiple implications for what we do as a sector, and we will touch on various aspects of these questions in this session. But the key thing, I think, is that sanitation quality is really important, and we need to understand it better, and we need to act on that understanding. And I'm having difficulties moving my slide, with apologies. Nikki, are you able to help me? Got it. Agenda. So this session is going to look at sanitation quality from various angles in both urban and rural contexts, and of course the challenges of rural sanitation and the challenges of urban sanitation show some similarities, but also a bunch of pretty important differences. On rural, we're going to be hearing from Andy Peel and Andy Robinson, and they're going to be talking about how the concept of safely managed sanitation services presents new questions for the rural sanitation sector, and that's particularly as more rural households transition from open defecation to using basic facilities. But at the moment, very little guidance is available on safely managed sanitation in rural areas. So Andy and Andy are going to be talking about new research from the Water Supply and Sanitation Collaborative Council, that's WSSCC, and UNICEF, which aims to shed light on standards for safely managed sanitation that can reduce pathogen hazards in rural contexts. We're also going to be hearing about 3 research projects which were delivered under WSUP's Urban Sanitation Research Initiative, which was a 4-year program of research funded by DFID. These 3 projects looked at various facets of sanitation quality in the urban context, and I'm going to leave it at that. The particular focus of each project will become clear as the session proceeds. Then towards the end of this session, we're going to get inputs from a group of panelists who are going to discuss the implications of this emerging research under the orchestral direction of my very learned colleague, Caroline van der Voorden. Just quickly, some housekeeping before we leap into this. I want to make clear that we will not have time for verbal responses to questions after the presentations, but we do very much encourage you to put questions in the chat box on the Pathable app, that's the conference app, and presenters will review these questions in the session or after the session, and they will respond via the chat. So we really do welcome questions, but we're not going to respond verbally, we will respond via the chat. Okay, so that is enough from me. I think let's jump straight into the meat of this. The first 2 presentations are around sanitation quality understood in terms of public health. So I'm handing over first to Freya Mills of the University of Technology, Sydney. And Freya is going to be talking about a piece of research around pathogen flow modeling in urban areas. Freya.
Thanks, Guy. Just great. And I'll actually pass over to Christine to kick us off with this presentation.
Yes. Okay. So good morning or good day, everyone. My name is Christine Moe from the Center for Global Safe Wash at Emory University. And together with my colleagues Freya Mills from University Technology Sydney and Nuhu Amin from ICDDRB, we're going to talk about what does quality sanitation look like in an urban setting from a public health perspective. We will present results of 2 studies we recently completed in Dhaka, Bangladesh, one about measuring and modeling fecal pathogen flows, and the other about how adults and children are exposed to fecal contamination in their environment. Okay, thank you, Freya. So from a public health perspective, it's critical for sanitation to protect the user from exposure to fecal contamination at the point of use, and also to protect the residential environment from fecal contamination moving throughout the neighborhood. When fecal contamination is released into the environment at any point in the sanitation service chain, it can contain fecal pathogens and become concentrated in various compartments of the environment, and there pose a health risk to residents who are exposed, either through direct ingestion, such as through contaminated drinking water and food, or indirect exposure, such as through contact with contaminated drain water. Next slide, please. We can examine risks from poor sanitation by measuring fecal contamination in the environment and how people interact with their environment. In our SaniPath studies in low-income neighborhoods around the world, we have seen how poor sanitation and fecal sludge management leads to widespread exposure to fecal contamination in the residential urban environment through the multiple pathways as shown in this diagram. We collected environmental samples from each of these pathways and tested them for fecal indicator bacteria. And in some cases, we also tested for pathogens. And we collected data on self-reported exposure behavior, such as type of drinking water consumed or contact with open drains. This presentation will demonstrate how we use this data from Dhaka to estimate exposure to fecal contamination and associated health outcomes, and used a modeling approach to predict the effect of different sanitation interventions. Now I'm going to hand the presentation over to Freya, who will talk more about quality challenges with current approaches to on-site sanitation in urban settings. And then Nuhu will talk about our results from Dhaka.
Thanks, Christine. Improved sanitation in the MGD period really focused on access to toilets that provided a barrier between the user and excreta. Through adequate flooring, water sealing of the pan, or covering of pits. While many countries such as Bangladesh made significant progress in access to improved toilets, such as shown by the limited and basic categories of the SDG ladder, there was little consideration to what happened after the toilet. And the reality is that much of this waste is discharged untreated into the environment. The SFD, or excreta flow diagram, of Dhaka shows that the quality of toilet is only one part of safely managed sanitation, and the benefits of eliminating exposure at the toilet can be negated as fecal waste enters the drains, living environments, water and food systems, as Christine pointed out, due to various failures across the sanitation service chain. This poses an exposure risk not just to the user, but now to the entire community. The majority of households in Dhaka, as per many developing countries, use on-site facilities, with sewage only serving a small portion of the city. On-site systems are promoted as an important part of achieving citywide sanitation. And while there's been increased focus on improving fecal sludge emptying and treatment services in Dhaka, from this SFD, it is evident that containment is one of the biggest challenges to safely manage sanitation. And with the largest portion of unsafe discharges in Dhaka coming from septic tanks to discharge to drains. A recent global assessment of 39 ship flow diagrams, or excreta flow diagrams, found that this is a global issue, with half of all septic tanks discharging to drains. While the septic tank systems are considered safely managed sanitation, septic tanks discharging to drains are not. Septic tanks only provide minimal treatment of pathogens, and the effluent requires further treatment. as seen on this textbook diagram of a septic tank on the right. This discharges to a soil absorption field. Alternatively, this could be a soak pit or to a pipe sewer that discharges to further treatment. The need for adequate separation distance between the absorption field and groundwater, and the reality on the left here that half of all soak pits are actually in high-risk groundwater areas, highlights the need for quality sanitation to not just consider the technology, but also whether the system is suitable for local conditions. While septic tanks are a commonly recommended solution for urban areas, to date there has been limited research on the performance of on-site systems in the conditions they are installed, used and managed. And despite the prevalence of both toilets and septic tanks discharging to drains, there has been very limited studies on the pathogen discharges to the environment from sanitation systems. As we grapple with options to improve sanitation, there remains critical questions about the extent to which on-site systems in these low-income urban settings are removing or inactivating pathogens, and are they actually protecting public health? Nehu from ICDDRB will now present the findings from the assessment of pathogen flows from sanitation in a slum area of Dhaka, in which 70% of the toilets discharge to drains and 24% to septic tanks that discharge to the drain.
Thanks, Priya. And as part of the recent project, we measure pathogen entering urban environments, and this provide an example of these containment issues in practice. In the first bar diagram, you can see frequency distribution of different pathogens along with different sample types. Different colors also representing the different pathogens, and you can see many of the samples tested positive. Particularly, most of the canal drain flood water samples are positive with a number of pathogens, including Vibrio cholera and Shigella. Importantly, septic tank and aviary effluents are also releasing significant amount of pathogens in the environment. And in the right side box plot, you can see the concentration of the pathogens, particularly Vibrio cholera, Shigella, were really high along with the E. coli. Next slide, please. And unfortunately, adding septic tank and investing for septic tank only made very limited improvement to the situation. And this slide, you can see the concentration of pathogens and E. coli in different roads with high, low, and no septic tank coverage in the study areas. And we found that drain samples from roads with high septic tank coverage generally had lower concentration of pathogens, except for Salmonella typhi. But concentration of E. coli were similar across the road, even with different level of septic tank coverage. And what actually does this mean and why this is happening? Particularly happen because of the septic tank only provide limited treatment, and the effluent should not actually discharge to the drain directly. And secondly, septic tank in these study areas actually rarely emptied actually, and particularly in our study area, we have seen that in 5 years there was no emptying of the septic tank, and as a result, solid waste could actually directly overflow into the drain, and that's the reason why the high level of contamination we have found.
Two-minute warning.
And next slide, please, Priya. So. In this photo, you can see that taken from our study area, and you can see the children are sitting beside the drain and taking snacks near the latrine. And evidence shows that from our Sanipath study that children are often come into the contact with drain and flood water while playing. And the tree plot arranged from left to right according to the SES of the neighborhood, and the size of the box and the darkness of the color relates to the pathway of the contribute more greatly to the population's total exposure within the neighborhood. And these plot actually showing that dominant pathway for children are drain, municipal water, surface water, produce, street food, and also the flood water. I just wanted to point out specifically the open drains that contributes more greatly to the exposure for the children compared to the adult. So that's from my slide. Freya, over to you again.
Thanks, Nuhu. I'll just talk about this slide briefly. This is actually the model converted to some of these pathogen findings using a DALI to compare sanitation options. And we developed a number of options and tested them in the model to understand how different sanitation solutions could possibly reduce the health risks. I won't go into all of these in detail. There's also been another presentation by Tim Foster and a paper available on these findings, but a key aspect that we included was whether the systems were actually managed or not, and really how the systems addressed the key exposure pathway, which in this site was to the open drains. One of the challenges or sort of investigated was whether septic tank coverage could actually significantly improve health risks. And as can be seen in option 1, there was really limited, even with every household in the study area received a septic tank, there'd be limited improvement in health risk. So I'll just pass to Christine because I know our time's running out.
Yeah, it's a wrap up.
Yeah, no, I think just to wrap up, in summary, our studies detected high concentrations of the various enteric pathogens in the drains and canals. We learned a lot about pathogen flows, but there are clearly many evidence gaps that you see on this slide here and a need for further work. And with that, we want to thank you all for your attention and our many collaborators for this project. Thank you.
Thank you so much, Christine, Nuhu, and Freya. That was fascinating. If anybody in the audience has questions for Freya and colleagues, please put them in the chat box on the Pathable app. Now we're going to move from urban to rural with the presentation from Andy Robinson and Andy Peel, based on a research study from WSSCC and a discussion paper from UNICEF, examining quality standards, programming gaps, and good practices, and recommendations for safely managed sanitation services in rural areas. Over to you, two Andys.
Thank you, Guy. Hello, everyone. I'm Andy Robinson, and I'll be presenting this work on safely managed sanitation services in rural areas with my colleague, Andy Peel. So our presentation summarizes two parallel pieces of work. The first one was a study on safely managed sanitation services in Global Sanitation Fund country programs for the WSSCC. And during the same period, development of a discussion paper on safely managed services for UNICEF's global toilet team. So we started in early 2018 with a review of safely managed services in rural areas. And as Guy said earlier, there wasn't a lot available at that time. We then reviewed approaches to safe management in 11 GSF country programs. As the map shows, 9 countries in Africa and 2 in Asia. And at the same time, the UNICEF review was ongoing. So some of the learning from the GSF reviews fed into the UNICEF work, and UNICEF also reviewed and discussed the work, which fed back into the GSF study in a slightly sort of iterative process. So in the end, we decided to align the findings and the presentation of the two pieces, and the two organizations agreed that we should make a joint presentation of the findings here. So now I will pass over to the other Andy to share some of the findings.
Thanks, Andy, and hello, everyone. As everybody here knows, I think, achieving Sustainable Development Goal Target 6.2 requires a focus on several issues, including sustaining safe toilet use, ensuring that excreta are safely contained in pits or tanks, and establishing systems to safely manage waste when pits and tanks fill up. And while there's been significant research to improve the sanitation service chain in urban settings, for instance, through the development of the ship flow diagram approach, which maps excreta flows along the service chain, there's little guidance available on how to achieve and sustain safely managed sanitation in rural contexts. The ship flow diagram approach broadly classifies all excreta flows as safe or unsafe, but this neglects the fact that not all pathogens are alike and that pathogen loadings change over time. For instance, due to processes that reduce viable pathogens like storage in pits and tanks and treatment through different processes. Work on pathogen hazards and flows, as we've just heard in such great detail in the first presentation by the team at UTS, the team at Emory University and by UNC, is important and has clearly revealed some really interesting findings. For example, UNC's 2019 study revealed that in the 4 low-income countries that they examined, 80% to 98% of unsafe release occurs in the first 3 steps, mainly because of open defecation, unsafe containment, and unsafe emptying. So only a small percentage of the excreta hazard in these countries currently reaches treatment. Although, of course, this may change over time as transport and treatment systems expand and improve. Interestingly, the same study suggests that the sanitation ladder is actually upside down, with the simple technologies on the bottom rung of the ladder proving safer than the more advanced technologies at the higher rungs. So pit latrines are safer than septic tanks, and septic tanks are safer than sewerage. And work by the Institute for Sustainable Futures at UTS, as we just heard, illustrates one of the reasons for the UNC finding, which is that the septic tank effluent is likely to contain many thousands of human infective doses per day and is therefore extremely unsafe. And the effluent outflows are therefore a significant concern, but are rarely monitored. Okay, so now I'll pass back to Andy Robinson.
So thanks, Andy. The next set of slides highlight some of the key issues. These were drawn from a series of desk reviews, also from reviews in the 11 GSF country programs, including discussions, interviews with program staff and stakeholders, from field visits to 4 of the country programs, and from discussions and feedback from various UNICEF teams. The GSF fieldwork that Andy and myself undertook was very interesting, as almost all of the GSF staff said that previously they'd not spent much time behind toilets looking at containment and whether it was safe or not, that most of the existing monitoring looked at the inside of the toilet, as Freya said, the slab, the pan, the superstructure. So this was a new thing for them. Our first issue slide is about poor flush latrines, as more issues were reported with this technology than with any other. Poor flush latrines usually flush to pits or septic tanks, and unsafe outflows from these containment systems are common, either continuously or occasionally. The first 2 photos, sort of the top row on the left, both show leaking pits in Cambodia. The first with the sort of red circle was a continuous leak from a hole in the ring. The second shows vegetation growing from occasional seasonal leaks. Where lined pits are used, the pits are often small and shallow, which means they tend to fill up fast and sometimes block and overflow. So we have a couple of pictures there of full and overflowing pits in Nepal. And this often leads to unsafe emptying, as emptying can be expensive. A survey in Cambodia found that 73% of households dump their fecal sludge within 500 meters of the house in a bid to sort of reduce costs and be able to continue using their toilets. Second issue slide on dry pit latrines. The issues here were less prevalent and generally less serious, largely because there's less liquid around to transport pathogens out of the pit. But we did find examples of unsafe containment, including a small percentage of latrine pits that were not properly covered when full, pits that had collapsed, and some pits that allowed sludge to flow out of the pit into the open. We also found considerable evidence of solid waste being added to pits, which obviously makes them fill up faster and creates some emptying problems, and of full pits not being safely covered and closed. So we have 2 examples in the middle here of toilets in Madagascar that are abandoned, but the pits were never closed. So they're dangerous for kids could fall in, and there's excreta exposed to the open. We also found people installing more permanent superstructures, such as the bottom right picture from Tanzania, which creates another set of issues as people change their practices. Third issue slide is around unsafe emptying. As we noted earlier, unsafe emptying, disposal and use are more prevalent where people use poor flush latrines, and sludge disposal from these facilities is often to the open, to drains, to water bodies, to fields. We already said that safe emptying and disposal services are often rare in rural areas. There's not many of them around in a lot of the contexts we looked at. And where they are available, they're expensive, so difficult for poor households to afford them. In some places, rural services are being developed. The photos show, the top three show vacuum emptying in rural Nepal, in the Tarai, which is then being disposed to a trench disposal site managed by the local government. The bottom two show manual emptying of pits in Uganda, which was being taken to disposal at a nearby treatment works. As you can see, sanitation workers don't always wear personal protective equipment. The Uganda workers are pretty good, but don't have any masks. In Nepal, the workers weren't wearing any PPE, even though it turned out they'd only been trained 3 weeks earlier. They had all the equipment, so they just hadn't taken them to work that day. Now I'll pass back to Andy Peel, who's going to talk about treatment and other issues.
Thanks, Andy. And just to reassure you, I've now turned off my phone. Apologies for that, everybody. Yeah, just a few comments on treatment. Then basically, few fecal sludge treatment plants are available or functional in most low and middle income countries, particularly in rural and the small town settings where we were looking. A recent review by WaterAid highlights the high failure rates and provides a long list of the main problems. For example, as you can see in the photos on the right, which show a fecal sludge treatment plant in a small town in Uganda, which receives so little fecal sludge that it's barely functioning. So an important point here is that significant capacity and resources are required to successfully manage a treatment plant, and these are rarely found in rural settings. Another key issue is groundwater contamination. The photos from Nepal show hand pumps right next to pit latrines with stagnant water sitting beside the water points. This highlights the risks that groundwater can be polluted by leaching of liquids from the toilets, particularly wet technologies, as we've been describing, such as poor flush pit latrines and septic tanks with soak pits. But here the context is really important. For example, the risk of groundwater contamination from on-site sanitation can be low in, for instance, fine-grained soils. And the recent research in Bangladesh found that in unsaturated alluvial soils, only 1% of the potential disease contribution from the fecal contamination occurs through the ground, with the majority of the concentration which happened either in the well and the pump, or when people were collecting and storing water, as indicated in the pie chart on the right. So there are many different issues to consider, and a risk assessment can be really useful to check the risk of groundwater contamination. Where toilets exist, and as we've been describing, the pathogen hazard is usually related to unsafe containment or to unsafe emptying and disposal. However, as the GSF outcome data here shows, hazards before excreta enter containment can also be significant. These include open defecation, use of unsafe toilets, and unsafe child excreta disposal. In all of these cases, 100% of the excreta is released unsafely to the local environment. And this data suggests that up to 25% of excreta flows do not actually reach the containment. And in both Cambodia and Tanzania, the unsafe child excreta disposal makes up a significant proportion of the unsafe flows and therefore needs to be measured. So we tried drawing ship flow diagrams for the GSF programs in Cambodia and Tanzania, and they look like this. And these illustrate some of the main issues and findings we've described. with the safely managed sanitation services shown in dark green. And we added a new feature to these diagrams with unsafe child excreta flows shown in blue. The lower proportion of the safely managed services in Cambodia is largely due to the widespread use of poor flush latrines and the unsafe emptying practices. But because a lot of the pits in these programs have not yet filled up, we had to make some assumptions about whether they are likely to be safely managed. And where survey data were available, we used that to model where the practices were likely to be safe. And of course, as these pits do fill up and then are emptied or not, monitoring will be important to capture whether or not the services are safely managed. So moving towards the end of the presentation, based on the study findings, we provided 4 system or program level recommendations. Firstly, that better and more reliable monitoring is required, with survey including observation of not only the toilet, but also the containment which is behind it or underneath it and to which it's connected. With regular monitoring, as over the time the pits and tanks fill up and are emptied or replaced, with data collected from service providers as well as from the households. And to improve quality and reliability, there should be internal checks and verification. It's also important that this monitoring then contributes to the national assessments, which means you're going to have to coordinate with the government, with others, to align the survey's indicators and the survey areas, and then think about the finance and the capacity. Secondly, this enhanced monitoring should be then used to identify the unsafe services and the high-risk practices. And ship flow diagrams are perhaps a useful tool for the data analysis, even in rural areas, although this may mean you have to create different ship flow diagrams and because of the different contexts and settings. And then you can use this to inform the programming policy and practice. And again, going back to the pathogen flows in the longer term, perhaps with more detailed data being available, you'd be able to refine the analysis and use the pathogen flows to encourage appropriate responses. Thirdly, the safely managed sanitation services are not only about what happens in the pit or after the pit. Open defecation, use of unsafe toilets and unsafe child excreta disposal remain the critical issues as well. And therefore unsafe excreta return before the containment should be a priority with targeted interventions and specific monitoring to address and track the progress. And finally, as we've already discussed earlier, the risk of the groundwater contamination should be considered. The ship flow diagram website provides a simple tool for doing a preliminary assessment, and that's based on the local soil type, groundwater level, proximity of toilets to water sources, and the type of water source. And then if there's the risk looks high, more intensive monitoring and a more detailed risk assessment may well be needed. And in some cases, it's good to remember that the best solution may be to protect or replace the drinking water supply rather than changing all of the sanitation services. Okay, thank you. I'll now pass back to Andy Robinson.
Thanks. So we tried to distill the key messages from the study into 5 principles that we think everyone should follow. Our first principle is that in most rural situations, you should store excreta in the ground, as this encourages pathogen die-off and reduces the risks of exposure. As the UNC study found, as soon as you start handling and moving around excreta, the risk of fecal exposure and unsafe disposal increases. So if there's space available and the risk of groundwater contamination is low, leave excreta in the ground and avoid emptying it. This works well in rural areas where people currently use dry pit latrines, but may change as people start to invest in more permanent toilets with lined pits that they want to empty. Principle 2 is to bury fecal sludge that is unsafe. So where fecal sludge has been stored for less than 2 years and has to be emptied and appropriate land is available, you should encourage burying in pits or trenches. Those emptying should use mechanical pumps and covered containers to minimize fecal exposure, and households and sanitation workers should be made aware of the health risks, trained in safe practices, and encouraged to use personal protective equipment. Principle 3 is to promote community level emptying and disposal systems. So here we're suggesting to organize a scheduled annual process that facilitates the monitoring and support of safe practices. First, identify pits or tanks. Okay, first identify pits or tanks that are likely to need emptying over the next year, dig communal trenches, inform and involve local service providers, and where required, provide PPE and emptying equipment. And where possible, local government support should be encouraged to reduce costs and regulate the process. The study confirmed that fecal sludge is often spread on fields for agricultural use, but there is little awareness of the risks of this practice, either related to the use of the crops, to worker safety, or the potential risks to nearby populations. So principle 4 is to raise awareness of the risks of agricultural use of fecal sludge. We need to improve monitoring of this and take action where unsafe practices are found. And finally, the 5th principle is that households should also be aware of the implications of safe management on their investment in it and use of toilets. So toilet superstructures and safe containment systems should be designed for easy emptying and replacement, and people should be encouraged to think about safe management before they invest and construct facilities or services. Related to this final point, we also need stronger regulation and monitoring to increase household incentives for safe management. But we wanted to make the point that we should not forget that some poor and marginalized people and groups may struggle to achieve safe management without assistance. And in these cases, targeted support and subsidies may be required. Hopefully, or our intention is we don't forget that the SDG sanitation target is also about achieving universal and equitable use of sanitation services. Okay, thank you. That's it from us. I'm now going to hand over to Mike Nilo, who was going to say a few words on what UNICEF is planning in this area.
Hi, everybody. Can you hear me? I'm sure.
Yes.
Right. I guess for us, this really rooted from a paper that was actually started at UNC, where we tried to rethink rural sanitation. I mean, as we know, we have our traditional approaches like community-led total sanitation and also market-based sanitation, and that kind of helps us with the containment part and the toilet part, but really still poses a couple of challenges that were left question marks when we were trying to develop our rethinking rural sanitation guidance. And they were really around two things. One was, you know, what safely managed sanitation means, which is what we've been discussing today. But also the other aspect is, you know, how do you work in challenging environments? From there, we were hoping that our new strategic plan will be able to incorporate, which starts in 2022. We'll be able to incorporate many of the findings, and we're starting to perhaps test some of these recommendations that have been put forward. I just wanted to also highlight that so far we've had discussions in two regions and also a couple of large country offices with regards to the relevance of the findings, and we've gotten quite positive feedback so far, particularly around you know, the alternate monitoring systems to national systems, as you know, as been pointed out today by the speakers. The current national monitoring systems are not accurately capturing what they need.
Mind if you wrap up?
Yeah, and the other two areas that people found really interesting was around the community emptying, and see how, you know, the current, you know, CLTS facilitators could get involved in both that and the socialization of safely managed services and the risks of and implications on the households. I'll end there. Hopefully we get to share more next year. Over.
Great. Thank you so much for that, Andy. And I'm trying to stop doing the Andy's jokes now. And our colleague from UNICEF, whose name I didn't catch, my apologies. That was really interesting to see the parallels between research that's been done in urban areas and in rural areas, and also very interesting to see the contrasting conclusions around whether waste can be stored on site or not. Again, if anybody has any questions, please just plug them into the chat box. So these presentations from Freya and colleagues and from Andy and Andy have looked at sanitation quality from the health perspective. But of course, we also need to consider sanitation quality from the perspective of user experience. So I'm going to jump now straight into our next presentation. And this one's from Vasco Shelbert of EAWAG Sandek and his colleague Dario Melli of ETH NADL in Zurich. And these guys are going to talk to us about sanitation quality in the context of shared sanitation. So over to you guys.
Okay, thank you, Guy. Yeah, my name is Vasco Shelbert. I'm from EAWAG Sandek. I hope you can see the screen. And I'll introduce the quiz study and the results to you together with my colleague, Dario Melli. Yeah, so let's jump into it. As
we're not seeing the screen.
You're not? Oh, that was clear. Okay. You're seeing it now?
Now that's good. Thank you.
Okay, perfect. Excuse. Okay, so welcome to the brief presentation of the results of the quiz study. QUIS is an abbreviation basically for quality indicators of shared sanitation facilities. The study was financed under the Urban Sanitation Research Initiative by WSUP, as Guy already mentioned. Let's quickly have a look at the background of this study. To evaluate progress towards the Sustainable Development Goals, the sanitation service ladder is used to benchmark and compare service levels across countries regarding access to and usage of safe sanitation. The service ladder, as we know, builds on the established improved, unimproved facility type classification. Improved sanitation facilities are those that are designed to hygienically separate excreta from human contact. As you can see at the image on the image at the bottom of this slide, the JMP service ladder divides improved sanitation facilities into 3 categories: limited, basic, and safely managed services. Private facilities that are not shared with other households are categorized as either basic or safely managed services, depending on how excreta are managed, as we just heard in both presentations. While both require the use of improved facilities, for safely managed facilities, the excreta are not only contained, but also disposed of safely. In contrast, shared sanitation facilities using an improved technology are at best classified as a limited solution, irrespective of how excreta are managed. The reason is that it is extremely difficult for global monitoring purposes to differentiate between shared toilets that are hygienic, accessible, and safe, and the more common ones which are poorly designed and managed. Be that as it may, in many low-income urban areas, shared sanitation facilities are often the only viable option. This is so because of poorly developed infrastructure and the lack of space, and high population growth and high poverty levels. While many shared facilities are indeed of unacceptable quality, others have been found to be a hygienically safe and socially and economically viable solution. Since the year 2000, the total number of users has increased and almost doubled from 335 million, or around 5% of the world population, to around 630 million, or around 8% by the end of 2017. Given the difficulties to monitor shared sanitation quality, our objective was to identify and explore key determinants of high quality shared sanitation in urban contexts. The ultimate goal was then to determine a set of indicators that would allow monitoring and evaluating shared sanitation quality. Using a mixed methods approach, we performed a detailed empirical assessment of the drivers and determinants of users' experience regarding quality sanitation, and second, an analysis to identify criteria that can provide the basis for implementing and policy setters to define minimum standards. Overall, the study was organized in 2 phases. Starting with an extensive literature review and conducting participatory community meetings with users of shared sanitation facilities, we explored user challenges and concerns. This provided the basis then to design the focus group discussion guidelines. And during the focus group discussions, we evaluated how users of shared sanitation facilities themselves define the quality and which aspects they consider as essential priorities. The findings from the qualitative phase then were used to design a household survey and an observation protocol, which enumerators used for a short quality assessment of the sanitation facility in use where the household surveys were performed. Quantitative data analysis was then performed to evaluate the feasibility of potential proxy indicators to assess shared sanitation quality. Overall, the study was performed in 3 cities in 3 countries, which were Kisumu in Kenya, Kumasi in Ghana, and Dhaka in Bangladesh. Shared sanitation facilities can be very diverse, and in fact, there does not exist an agreed on typology. Adopting the categorization developed by Evans, we focused on A, users of shared household toilets, and B, compound toilets, whereas we did not consider C and D, which are community toilets and public toilets. We also collected data on individual household facilities to compare shared sanitation data. Okay, let's come to the results. Based on the focus group discussion for the qualitative phase, in a descending order, the user priorities identified were immediate water access, cleanliness, gender-separated toilets, flush toilets, lighting for use at night, lockable and functional doors, tiling, hand washing stations, and privacy. From the evaluated user quality priorities, cleanliness and privacy can be considered as outcome variables. This means their provision is dependent on other factors, including but not limited to outline priorities that you can now see on the left-hand side. While some of them provide or contribute to establishing cleanliness, others affect privacy, and some additionally affect safety or security, an additional outcome variable. Taking into account the identified outcome variables, we classify the remaining 7 quality priorities as outlined in this table. On the one hand, these findings informed the design of our household survey and the observation checklist for the quantitative phase. And on the other hand, these findings informed the development of the Sanitation Quality Index, the SQI, a quality outcome measure, which considers cleanliness, safety, security, and privacy that a toilet facility provides. Handing over to Dario.
Okay, thank you, Vasco. So to test which toilet characteristics are useful indicators for high toilet quality, we surveyed 3,600 households and conducted over 2,000 spot checks of shared and private toilet facilities. Based on the results from the qualitative part of the study, we defined 4 quality outcome dimensions, which are the availability and the accessibility, safety and security, and the privacy and the cleanliness of the toilet facilities. To each of these outcome dimensions, we assigned toilet characteristics that were part of the spot check observation. Those characteristics were observable outcome variables, such as whether the toilet's wall is solid and therefore provides privacy, or the toilet's cleanliness measured by the presence of solid waste, insects, and visible feces inside the cubicle. We then aggregated these outcome variables into a single outcome measure called the Sanitation Quality Index, or short SQI, using principal component analysis. After that, we regressed this index on technical variables like the toilet technology and social variables like the number of sharing households that had come up in some form during the qualitative part of the study. Let's first have a closer look at the outcome measure, the Sanitation Quality Index. The graph on the left-hand side shows the distribution of the Sanitation Quality Index scores in each of the 3 settings. It tells us that toilet quality varies considerably across the 3 settings. While in Ghana, more than 75% of the toilets have high quality scores between 80 and 100, we find a much more even distribution in Kenya, where we also observe many toilets with lower quality scores. The results for Bangladesh are somewhere between the two, although closer to Kenya than to Ghana. Closer to Ghana than to Kenya, excuse me. The regression analysis revealed 4 main findings. Mainly that most shared toilets in our sample used an improved sanitation technology. Second, that the toilet technology is the most influential indicator for toilet quality, but in our context, it was not decisive whether the toilet was improved or unimproved, but rather whether it was a poor flush toilet as opposed to a pit latrine.
Okay, wrap up time.
Yeah. We also found that on average, private household toilets have higher quality scores than shared toilets. But when we control for other toilet characteristics, this correlation decreases and becomes insignificant. We found that the toilet's location, whether the toilet has a lockable door and whether there is a working light for the use, at night, are all important predictors and could therefore be considered as quality indicators in the case of shared sanitation. So just quickly for the conclusions, our research shows that the users and their perspectives on sanitation priorities are fundamental to consider. It is so both in terms of trying to meet their needs with public investments or in terms of ensuring user acceptance and thus supporting intervention success. Additionally, the quantitative analysis revealed that distinguishing different improved toilet types would improve the assessment of shared sanitation quality in the urban context compared to the sanitation service letter as proposed by JMP. Lastly, we found that other variables such as the toilet's location, lockable doors, and lighting are highly predictive of sanitation quality and could complement or substitute current indicators. So that wraps up our presentation.
I need to rudely wrap you up there, Vasco and Dario, because we are running out of time, and apologies to everyone for rushing through this. I know we need more time. That was brilliant. Many thanks. Again, please post questions in the chat box. Now we come to the final presentation from Ben Tidwell, who is going to be talking to us about user experiences of container-based sanitation.
Thanks, Guy. I wanted to share just quickly here at the end. I know it's been a lot of data and you guys are looking forward to some discussion of different approaches and trade-offs between these. So I wanted to share a little bit about our study in Kumasi, Ghana. This slide shows a quick overview. You can read what's on there, but I think related to or in comparison to the prior presentations, there's a couple of things. I realized I'm not actually turned on my video, I don't think here. Not that you need to see me, the slides are probably sufficient. But the 2 things I would say to contrast this approach to the prior presentation are, one, we were primarily looking at public toilets rather than on-plot shared facilities. And so in Kumasi, often people walk, the typical distance is about 14 minutes round trip travel time to use these toilets. And so they're a bit different than what was being looked at previously. And second is that we're looking not at an infrastructure assessment as our endpoint, but particularly at satisfaction and really quality of life associated with these sanitation services. So it's not just about what is the quality of the infrastructure. It's not just about what is the quality of the service being delivered in some way, but really how do users experience these kinds of sanitation. And I'll talk a little bit at the end about our findings and implications for monitoring. So briefly, access to safely managed sanitation in Ghana is low, and there are very few affordable and acceptable options, especially for a setting like Kumasi, where there are many dense, informal, low-income settlements. And so space is at a premium, and there are not a lot of finances available. We wanted to explore in this study particularly whether container-based sanitation could be a solution. And I mean this not just as delivering a quality service that people are willing to pay for or related to health outcomes, but really, you know, if people are getting this service, is this kind of a step from very low on the, you know, I don't want to use ladder to confuse with sanitation ladder, but very low on a user experience rating, you know, just making a small step up where really, you know, it's not making a huge difference, or are we looking at a relatively large jump? And so while this might not be quite as aspirational as, say, a private on-plot flushing toilet to a sewer system or something like that, is it making a significant improvement in user experiences? And so really the aim of the study was to evaluate the satisfaction and quality of life associated with use of this toilet. So we conducted a longitudinal prospective cohort study of new customers. And what that meant is that we surveyed customers right before they had these toilets installed, and then 10 weeks later, so that we could understand what their experiences were at the time of installation with their prior kind of sanitation, and also how they felt after some amount of time to adjust to, you know, challenges in using a new technology, or maybe you know, just some over-reporting satisfaction because they were, you know, happy with a new purchase that they'd made. We chose this study design really because the goal was not to say, should a government give everyone or heavily subsidize container-based sanitation, but to say, of those who use it, is it significantly impacting their quality of life? And so we did look at outcomes related to infrastructure, but also service quality. As you can see there, the quality of the sanitation experience, the satisfaction, and then in particular, this measure sanitation-related quality of life. And I won't go into too much detail here. There's a presentation later in the day that'll go into more detail on this, but really the idea is to develop an easy to deploy measure of quality of life. In fact, the actual endpoint of this is 5 multiple choice questions. Are you able to use, you know, your sanitation and always feel and feel clean always, sometimes, rarely, or never, for example. So something that's easily deployable and measurable across different contexts. We also had as a part of this study, a qualitative assessment of customer and leaver experiences. So I want to just present sort of 3 highlights. So first, to set the stage, what was the situation pre-Clean Team versus the Clean Team toilet? So as I said, most people in this setting were using a public toilet. Even those that weren't were usually sharing with other households. As you can see, the infrastructure quality was generally high in terms of containment. You can see most of these public toilets were flushing to a septic tank, and on-plot toilets were VIP latrines or flushing to pit latrines. So at least in the user interface, we're talking about generally high quality. You can see there, though, that there's some challenges around hand washing and certainly a round trip time that's associated with the density of these public toilets in this setting. Compared to that, these aren't necessarily comparable measures, but what we were wanting to see really is, are we talking about kind of a relatively good quality of public toilet versus a relatively good quality type of container-based or instance of container-based sanitation, so we can make those comparisons meaningfully and not just compare good container sanitation to very, very poor public toilets. So as you can see there, the container-based sanitation, the Clean Team toilets were relatively well-functioning technologically, and also the service was high quality with very few experiencing challenges in the service delivery. So the 2 points I want to share on how users experience this. So we evaluated 5 SANQUAL dimensions and then 5 additional ones, since SANQUAL was still in development at that point. We wanted to try to capture alternative categories that might be of more importance, and also try to see how those vary by setting, as this was originally developed in Maputo for the MAPSAN trial. So they're scored from 0, never, to 3, always, and higher is better. Sometimes the phrasing and the reporting is negated a little bit so that the inverse coding makes sense. So the point of this, I don't want you to try to suss out every little line here or something like that, but really there's a few that are indicated. So the triangle and the square there that's sort of high at the outset, we're not worrying about assault and not worrying about cost. Those were relatively stable across public toilets and clean team toilets. Generally speaking, all of the other categories that we assessed increased pretty significantly, certainly statistically significantly, but more important, moving from about 1.7 on average on this 0 to 3 scale to about 2.7. And you can see in particular that feeling pride in your toilet and not worrying about a sense of smell increased substantially. The last point I wanted to make was just, we looked at some gender and disability concerns. So both gendered behaviors, so practicing MHM or combining household duties with using the toilet, and saw drastic increases in those related to having the container-based toilet, and decreases in challenges with using a toilet at night. But then even across these things that are not inherently gendered, so ease of access and ease of use, we saw that there were gaps at baseline, and these gaps were all closed, and even females had slightly higher ratings than males on all of these categories. So really, the clean team toilets functioned well and the service was delivered effectively. The public toilets were of relatively high quality. And so we can see here customer satisfaction and quality of life increased in almost every domain that we measured, including particularly, as I mentioned, bad smells and ability to feel pride in one's toilet. As you can see there also, satisfaction scores increased related to gender and disability. And so I think what we can see here in comparison to the prior study is that while public toilets might be necessary in some places for some period of time, even what we would say maybe not the most aspirational kind of private sanitation delivered delivered very high quality of life score outcomes. And also those were very close to being as high as they could be. It wasn't as if container-based sanitation was some small step up, but delivered a very high quality service and quality of life outcome. I'll stop there. Thanks.
Many thanks indeed, Ben, and thanks for being quick, which is really appreciated. That was a great presentation to round off. I would love to comment on these presentations, but at this point, I just want to say thank you to all our brilliant presenters and the really interesting research they presented. I'm going to hand over immediately to Caroline van der Voorden, who will be, bear with me while I just...
Yeah, I'm here.
The screen, who will be leading the panel discussion. Over to you, Caroline.
Thanks, Guy, and thanks everybody. Yes, and we will keep this quick. We are aware we're a little bit behind on time, but we have three very learned team members, panel members among us who have done work on all these issues. So we did want to give them a chance to comment on some of the presentations and to make some connections. So we have Kate Medlicott, who is the sanitation and wastewater team leader in the WASH team in WHO, and one of the lead authors on the sanitation and health guidelines. We have Antoinette Como, who is the global sector coordinator for WASH at SNV, and Ian Ross, who is a PhD researcher at the London School of Hygiene and Tropical Medicine, but also one of the architects of the SANCOL methodology that was just presented. So kicking off, if I may, with Antoinette, SNV has done a lot of work on safely managed sanitation and particularly in rural areas. And so we wanted to ask you really what you see, what your thoughts are on the next priorities and future challenges for addressing safely managed sanitation in rural areas for the rural sanitation sector as a whole, based on the experiences of SNV's SH4H program, but also more widely.
Yeah, the first challenge is maybe, or hi everybody. The first challenge is maybe the dogma that you're facing, because many people, when they hear safely managed sanitation, they think, oh, that's FSM, we need to empty and transport and treatment. And I've been in several conversations in different countries trying to say, no, not necessarily that emptying is the same as safely managed. This is about how can we avoid human excreta coming into contact with people. So separate human excreta from human contact, that's the basis. So contradicting that dogma and really getting everybody's awareness that safely managed is not the same as emptying, I think is very important for our sector, especially for rural. The second bit is, of course, that you want people to think about the life cycle of their toilet, if you want, at the moment of construction and not 10 years later. And so we need to get much better at informed choice, at talking people through about and understand what they're getting themselves into. And start planning for that replacement or closure of the toilet and so on.
Thanks, Antoinette. I may come back to you later if we still have another minute. But now I'll hand over to Kate. Kate, can you talk a little bit about how the research presented relates to the WHO guidelines for sanitation and health, and really link to that? What do you think are the most important implications for local or national health authorities of some of the guidelines, but also some of these new studies that have come out?
Yeah, I mean, I think what was really exciting to me about all of these presentations is everybody was talking about risk assessment and management approaches, really thinking about the health consequences of the way that they're programming, whether that's around the kind of well-being aspects that would encourage use and dignity, or pathogen flows from those facilities. And that's really what the guidelines are entirely about, is trying to make sure that we get the maximum health impact out of these sanitation investments. And I think we're all super busy in the sanitation sector thinking about behavior change, about technologies, about service models, about financing, about institutional arrangements. And I think what the kind of body of evidence is really pointing to is that within that, we've also got to be really taking a stronger risk-based approach to sanitation services. And that's really what the guidelines do, is they extend on the JMP ladder definitions, which are for monitoring purposes, and go further into that kind of implementation detail on the what and the how. And of course, what we always are talking about is risk assessment and management, or sanitation safety planning. And that's really about, systematically, as we've seen in these presentations, trying to understand how are the interventions we're proposing impacting on health, and then systematically building those barriers, whether those are technological barriers, changes in behavior, changes in management of systems, to really break transmission. And it's actually not a new thing at all. Actually, everybody knows the John Snow story of cholera, and that's exactly what they did, was like systematically go around and understand what's happening with transmission and